We were just waiting for our speaker to join. Thank you.
Sonia, first you find out whether sir is audio is on. Dr. Prakash Trivedi, good evening. He shared his presentation.
Yeah, he shared his presentation.
Sometimes these hitches will be there.
That's the topic all about, sir. That's the topic in laparoscopy in pregnancy.
Correct.
So, sir, actually we see your name on screen, but you're muted, sir. Could you just switch on your audio and video, sir? We can see sir's name displayed.
Yeah. Prakash, can you open your audio and video? Dr. Prakash Trivedi.
Yes, sir.
Now you can hear it.
Yeah.
Yes, sir.
Yeah, you can switch on the video also, Prakash.
Yeah.
And we'll start. And I welcome you on behalf of KCOG Kasoga. But let us start with the prayer. Arun?
Yeah, please.
Yeah, thank you, Mr. Arun. Sir, Dr. Bellet, sir, with your permission, I'll just take 1 minute just to thank all those who have logged in for their patience, and also a warm welcome to all our seniors, our dear colleagues, Foxians who have already logged in, the Kasogians and the KCOG members. And today's program is very meaningful as it reflects the KCOG's commitment to bringing relevant, evidence-based and clinically applicable topics to all our members. Before we start, may I now request our President of Kasoga, Dr. Durgadas Asrana sir, for his opening remarks.
Respected Dr. Prakash Trivedi and our own family of Kasoga. Good evening, everybody. Today, Kasoga is very much honored by the presence of Dr. Prakash Trivedi, one of the legends of laparoscopic surgery, not only in India but at the international forum. I thank Dr. M.B. Bellat for this arrangement. Laparoscopy in pregnancy is a very important topic wherein we need to know about the indications for surgery and also the technique of doing surgery in pregnancy which differs from the regular laparoscopic surgery. I'm very happy that Prakash Trivedi always talks on the practical aspects. So we all will have lots of take-home messages. So once again, I thank Dr. Prakash Trivedi from the bottom of my heart for accepting our invitation. Thank you.
Thank you so much, sir. Thank you, sir. And I'm confident that today's webinar will be enriching learning experience, as you have said. But taking forward the session, may I now request our beloved Dean of KCOG, Sir Dr. Bellet, for the proceedings.
Good evening to everyone, and Dr. Prakash Trivedi, today's important person and the very well-known endoscopic surgeon, both nationally and globally, and my president of Kasoga, all the secretary of Kasoga, Dr. Shobha, Dr. Sonia from KCOG, and all the senior members, my colleagues, and Dr. Metgood, who specially joined from London. He's on the way to US, my own colleague of from the department, and all the other respected members. It is a proud moment for me to have this webinar today. We are not going to take much time, but however, I feel that to introduce Dr. Prakash Trivedi for the others, we know him because I first time came to meet him in '96. He came for the suturing skills at Ruby Hall in Pune. But since then, I have been hearing him in many academic forums, and it was a pleasure to have him. And we heard him in Pune about this. He was not having adequate time for his presentation. I requested him that you have a beautiful presentation. Let us see from you all the laparoscopic surgeries. They are worth to be seen. So, Dr. Prakash Trivedi is a well-known endoscopic surgeon. He is a director of Trivedi's Total Women's Health Care Hospital at Akar IVF and ICSI Center, and his Maharashtra University Health Sciences recognized postdoctoral fellowship training in minimally access surgery. He is recipient of many awards, and he is first and pioneer in many of these, like 3D, 4K laparoscopic, histoscopic urogynecological surgery. He is father of fibroid and female urinary incontinence research and management, recipient of Senior Scientist National Award for designing cost-effective urinary incontinence correction tape, and he's since 2002 he's using that, and he's the American Laparoscopic Best Research Breakthrough Award for in-bag contained morcellation of fibroids and large uterus with fibroid.
Sir, you're muted, sir.
Okay.
Yes, sir.
Can you hear now?
Yes, sir.
He has performed more than...
Bella, don't introduce me more.
Okay, no. It is a proud moment for the KCOG and Kasoga, and it is your greatness that you agreed to be available on this webinar. Thank you. I request Dr. Prakash to proceed with his presentation.
So, Bella, you can hear me?
Yes.
Yes.
Okay. Whether you see or not, Ishan Kishan has scored a century against New Zealand. 226 for 3 in 17 overs.
So nice, very nice.
So that's a big plus point.
Okay.
I am.
Sir, we cannot see you. We cannot see you. I think your video is off.
I don't know.
You have to on the video out. Yeah, your video is off. Can you on it?
Yeah, video is on, but videos, which I don't know where it is. Caps lock.
You have below lower section in the Zoom. Left lower section.
Whether I am seen or not, I am heard, na?
Yeah, but presentation we should see.
Presentation you are seeing.
No,
sir. No,
Slides.
not yet. Slide sharing has not started yet.
Slide sharing is not started. Okay. I'll go in and this happens, when Ishan Kishan hits a century so fast.
So you were watching the match.
42
no,
balls.
My servant gave me, sir, धुलाई हो रही है.
Yep, 42 balls, 103 runs. 10 sixes.
Yeah.
10 sixes.
Yeah. I'm surprised why my video is not on. It will be on in a moment.
Yes.
Okay, sir. Okay, sir.
So maybe I may minimize this and put.
Initially, you could share those.
The slides we could see initially.
We could see that, sir.
The slides, so I will just get my video on.
Yeah.
Video was cancelled. Now you can see
Yeah,
me.
yeah. I can see you now.
And share it.
Yes, sir.
And we will go ahead.
Presentation needs to be opened up.
Yeah. Mm. Is it open now?
No, you are seen, but the slide presentation is not open.
Okay. Now?
No.
No?
I think you need to first open the presentation and then share it.
Share.
Yeah. First open the presentation on the laptop.
Open the presentation.
And then share that. Go to the screen share and.
I know this I've done so many times, but every time is a new time. I'm reducing this and I'll have to go to share.
Yes.
Share.
Yes. But your presentation, you open it instead of this desktop total. Yes. And make it slideshow. Yes.
Okay, sir.
Fantastic. Yes, fantastic.
Sorry for the delay.
No,
because 2, 3, 4 is going on, and I'm equally interested. But a great pleasure to be part of KCOG, Bellard, and all of you on talking on a very important subject on laparoscopic surgery in pregnancy. Can you hear me properly?
Yeah. Absolutely fine.
You can hear me properly?
Yes, Prakash. Absolutely fine.
Can you hear me?
Yeah. Are you muted? Your slideshow is there.
Hello.
Hello, we can hear you.
Can you hear me properly?
Yes.
Yes, you're very
But
clear.
can you hear me?
Yes. Very clear.
So I'm saying mute.
No. You are not
You
muted.
can hear me.
We can hear you.
Yeah.
So I will go on the light share which was going on.
It is there.
Yeah.
Next, you can click that 4 arrows button is there. Down, you can go. Next slide will come.
Now, I think so you can hear and see me, and you can see the slides also.
Absolutely.
So laparoscopic surgery in pregnancy. Now, fortunately, because of all of you, we have 52 to 55,000 laparoscopic surgery from 1992 till date. But when we do laparoscopic surgery in pregnancy, you will be shocked and surprised that how pregnancy accepts laparoscopic surgery, protecting the pregnancy. And compared to any open surgery, laparoscopic surgery becomes much easier and much safer. Now, there are certain concerns about duration of pregnancy. So there are reports that at even 20 to 30 weeks, people have operated kidney cancer. So you have to understand that once your Veress needle is in, once you anesthetize and the parameters are normal, after that the surgery is like any other surgery, only 3 precautions you have to take it. A, don't touch the uterus. B, whatever the problem is, you have to address. And you will see many problems which we address. Then effect of anesthesia on fetus and CO2. We have observed none of our patients had any problem. And unusual and rare cases also will be sharing with you. Possible need of laparoscopic surgery is twisted ovarian cyst, heterotrophic, cerclage, caesarean scar, endometriosis, myomectomy, appendicectomy, cholecystectomy, and as I told you, a rare renal cancer. Now, this is a interesting case. You can see a pregnant uterus with large ovarian cyst, and sometimes you don't have only one twisted ovarian cyst. You may have more than one ovarian cyst. So now when the patient presents to you with pain, like in this case, if you see the surgery is not very necessarily difficult. But the point is, if you can see, we are not touching the uterus. This was a dermoid cyst with pregnancy, and we removed it in a bag. So basically, we have to remember, apart from tocolysis and other things, what you give, principle of laparoscopy doesn't change. So as it's dermoid, we are draining out the fluid, and then we'll put it into the bag. So now we put it into the bag so that there is no spillage. Now all these things looks actually fascinating, but after 50,000 plus surgery, this is very routine for most of us. Whether it's Billard or whether it's anybody in KSOG, it's only mind plays the game. Surgery is done by hands. So we remove the dermoid, and in the bag, we will remove it through one of the port. But taking care of hemostasis and taking care that we didn't touch the uterus at all. There are a few suggestions that we should take 1 or 2 stitches, which I'm not always sure, but stitches are taken so that it doesn't have any problem of adhesion. So we move to a large ovarian cyst with pregnancy. And you have to remember there's the pregnancy and there's the cyst. Now, large ovarian cyst is a cakewalk because you have to identify, you have to drain the cyst. Now, this is taken when I was operating in Delhi with Alka Kriplani. We removed the entire fluid, which was 800 ml or so. And then we went ahead and we did the cystectomy. Now, few very important things you have to realize. Principles of laparoscopic surgery doesn't change. And principle of laparoscopic surgery doesn't change in the sense that the principle is to be maintained. At the same time, no touch technique. No touch technique means not manipulating the uterus too much. So that is what is necessary. Then hemostasis is achieved. Taking suture, etc., is optional. Now, this is a more interesting case. You can see pregnancy, twisted ovarian cyst on one side, totally dark and totally gone. You don't have to worry about the blackness. No twisted ovarian cyst needs removal. This is a study not only of ours, but many people. She's having multiple twists. But when you correct the twist, it, it regains its vascularity. So you correct the twist, and as I told you, the whole surgery is in your mind. So you can anti-twist also. Then after the now the cyst is twisted properly, then you drain off the cyst and then move further. You have to be very careful because the IP ligament is not far. Once you take out cyst as Hardik Pandya has got out, that's okay. The tubes also get twisted, but your agenda is leave the tube as it is, and Durgaza sir, no black ovarian cyst is ever needed for oophorectomy. All that you do is drain and remove. Now, this is what we want to show. One side the twist is dark, and other side the twist is normal. So, hot dog technique is used wherein you take a suture from the round ligament, then you take a suture passing below the tubes, and you take a stitch. Now, what does this stitch do? You go back from the ovarian suspensory ligament, and also you go back to the round ligament. So when you take this stitch, the possibility of cyst twisting is out of question. This is a very simple procedure. This is just you are taking a stitch. It's not anything big, and then you tackle and handle this cyst. So you number one, first prevented any formation of the cyst. And to my surprise and good news, Ishan Kishan has scored a century, I think so. My screen is going on my left side. Uh, then we do support the ovary in such a way that it has no chance apart from your even cyst. So it is suspended with the ovarian suspensory ligament, and we take a stitch so that you took
Your audio is not there, Prakash.
have any problem.
The audio is getting interrupted. Interrupted audio. If
This is
the
known as a hot dog hamburger. Though between you and me, Trump will not last beyond 6 February.
hello,
Was
You,
what was my audio on up till now?
no,
now it is clear, but the screen is gone.
Uh, now the screen is on.
Yes, yes,
Prior to that, you heard me or you didn't hear
yes,
me?
yes, we could hear you. We could hear
yes,
you.
And you could see also. No?
Yes,
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 yes.
yes.
Yeah. So this is a normal ovary which was also twisted. And so we are taking that hot dog hamburger stitch which goes from round ligament posteriorly to the round ligament, and again it comes back. Now, once that stitch is taken, the important point is that retwist doesn't take place. Once the retwist doesn't take place, then you can handle the cyst as you want. Now this is another patient, 26 weeks, and you will get an idea. Nice pregnant uterus, but what is she having? Again, right-sided multiple twisted cysts. Now the number of laparoscopic surgery done in pregnancy, when we reported in AHL, our series was one of the largest, like fibroid and many others. But the point important is you don't disturb the uterus much. So you keep untwisting. Now this is very important because if you over twist it, it can become more. So you have to get an idea. Now here the tube also is twisted. You can see the changes on the tube. Never remove the tube and never bother about the
Color.
contents of the cyst. Again, you will take the same stitch which we showed you earlier, and after taking the stitch, this is the same one you're taking through the infundibulopelvic, then you will go below, you will go on the ovary, and you will go below the tube and come to the round ligament. Now, this is done so that the twist doesn't take place again. So that is point number one. I am showing you the crucial step. Obviously, the cyst is drained out, everything is corrected, so there is no further problem. My purpose to show is the important part. Now, this is one of the historic case. I had, this is prehistoric. Heterotropic pregnancy can take place nowadays in IVF. Nowadays means I'm talking from 1999. And you can just go ahead and do a salpingectomy, which is not a very big issue, and continue the pregnancy. You have to give tocolysis. If you don't handle the tissue much, then automatically it gets stabilized. This was one case wherein in 1995, when I returned from Tunis, I was dreaming that why don't we get a rudimentary horn pregnancy? And within a few months, I got one rudimentary horn pregnancy. So this is one of the horn where I'm incising. Once incising, it's like breech delivery in the peritoneal cavity. So that's the fetus which is coming out. Now, obviously, I could have removed the horn totally because eventually we are going to remove the horn. But when you will get an opportunity to see a breech delivery intra-abdominal, and also you remove the placenta, now we have an option of closing the rent. Now we removed the ectopic pregnancy, but then we went ahead and dissected the horn so that the same mistake doesn't happen second time. Bilateral tubal pregnancy can take place, and you have to remember meta-analysis shows that you can have bilateral pregnancy. Bilateral means bilateral, tubal and intrauterine. So you can easily remove that. This is one of the historic case. I had way back spontaneous intrauterine and bilateral extrauterine pregnancy. Never happened in the world. But she wanted removal of all the pregnancies. So we are doing a salpingostomy, removing pregnancy from the left side, removing pregnancy from the right side, and obviously doing a termination of pregnancy from below. Now, this patient was so aggressive, she got spontaneous triple pregnancy, most rare in the world. We did this 6 months later. I was in AGL in America, and she had again an ectopic pregnancy. My role model and my teacher and guide, Dr. D.K. Tang, they did an open surgery. So this is on the other side. So again, vasopressin injection and dealing with pregnancy. Both the tubes gone, both the tubes pregnancy gone. And then we did an MTP. MTP is a standard MTP, that's not a problem. But in 6 months, she was staying in Hawaii and super fertile. So she had one more ectopic pregnancy, but I was in USA and our sir did an open surgery, acceptable. And these are few of the rarest cases in the world. Then this was a beautiful case. Firoza and me in Jaslok Hospital, we whatever treatment we did, but my follower from South Bombay, he called me in the night. He said, her ectopic is not important, but she was having twisted ovarian cysts. And can you believe, I don't want to name the famous hospital where film star go and deliver. In the night, they told, okay, 12 o'clock, we don't do urine pregnancy test. Forget about beta HCG. So I removed the ectopic. And he told, main complaint is on the other side. And this is the main complaint. So she had pain more on the right side. So we untwisted that ovarian cyst. And after removing it, in ovarian cyst, all that you have to do is you untwist. You can take hot dog bone stitch, but you puncture the ovary, and that is all what you have to do it. And this I did at 12:30 in the night. And next day when I inquired, how is the patient? At 8 o'clock, which patient? Patient is already gone. So patient was discharged in 7 hours. So that is what can happen. Now this is another interesting patient wherein there was previous cesarean section, and nowadays we keep hearing a lot about scar endometrium, scar pregnancy, etc., etc. So we kept on dissecting. We dissected the area. We went through the ectopic above and below. By above and below is because if you don't go above and below, you cannot suture it. So we removed the cesarean scar ectopic. So that's a pregnancy which is removed. And then you have to suture almost, that's a pregnancy. You have to suture. So again, like the early one, wherein you saw breech delivery in abdomen, this is a cesarean scar ectopic which is getting delivered. Once you get it delivered, you have to separate the bladder adequately. The dilator, you can see it. So on the dilator, then you can suture it with whatever material. Of course, nowadays preferred is the V-lock. So you can suture that area properly and you can achieve hemostasis. So whether we are aware or not, all such cases can take place. And it is basically for a laparoscopic surgeon, it is not difficult at all. Now this is one of the rare case wherein I was in Delhi with Alka Kriplani, and this was the picture which was shown to me. So you can see there is a scar ectopic pregnancy. So nicely we injected vasopressin, and when we went ahead and we removed it. And what happened is this must be probably the 40th case or even earlier, which was cesarean scar vesicular mole, which is not reported so frequently. So I went ahead, dissected, and as I dissected, it was a bizarre pregnancy. I freely use vasopressin diluted in standard format. From 1997, we don't have any problem. Let the whole world have a problem. My anesthetist is sleeping when even I'm injecting vasopressin. He doesn't bother too much. And this is what you can see. This is the vesicular mole, one of the rarest cesarean scar ectopic. So he went ahead, we removed this pregnancy, and then we sutured it properly. Now, while suturing, you have to take care. Don't suture it loosely. Otherwise, it will leave another isthmocele and you will have one more ectopic pregnancy. So you suture it nicely and properly. We have removed the product from cervix because you can easily remove the product from cervix. Alka insisted, नहीं थोड़ा suction curettage भी कर डालो. So I couldn't refuse her. So we did that. And then with V-lock, you can suture watertight. And we obviously in V-lock, everybody knows we do a baseball suturing. So we did a baseball suturing and sutured the defect in 2 layers. Now that is very important to suture in 2 layers. Why? Because we don't want a future ectopic in the same place. So now in 1995, Charles Coe used to tell that Dr. Trivedi's laparoscopic myomectomy is microsurgical suturing superior than open surgery. 1995. We are talking now of much later phase. We go to another important case. You can see a scar. You can see a bulging membrane. 20 weeks plus pregnancy. I have so many of such patients. And I have too much of patience. So all that you have to do is you dissect the bladder. And after dissecting the bladder, you have to create a window. This is one important thing which I learned from Hafiz. To creating window, it makes everything very simple and easy. So once you create a window, then you have the same tape which we otherwise use in cerclage. So because of the window, you are not worried and you want to remain medial to the uterine vessel. Then because of the window, you go on the opposite side and again you go medial to the uterine vessel. Why medial to the uterine vessel? Because if we continue as it is, then she will have an IUGR. So you tighten it and placements. So many interval cerclage, non-pregnancy cerclage. I have done from 5 patients from Australia. I have done from so many patients from Pune, from Nagpur, and so many other things. So you stabilize, and then this works well. Now this is crumpled up area. You ignore this crumpled up area because it doesn't do anything. This is another interesting patient. Again, pregnancy. And the problem she had was not only pregnancy, but the problem was, as we see further, it was even more advanced than the previous pregnancy. So I'll skip this. We went ahead, we created a window, 26 weeks pregnancy, and we did surplus. So basically, you have to understand that you don't have to be scared. At the same time, I don't reduce my pressure to 12 or something. I keep my pressure normal, and everything goes ahead. This is a very interesting case. Severe pain with pregnancy. That was because of a twisted fibroid. So this was a twisted fibroid, and she had another 7, 8 other fibroids. So we went ahead, and my son always is fond of suturing. Otherwise, I would have used ligashore and closed it. But I don't know whether this presentation will have the historic case which was operated by Prashant, Rakesh, and me, all three. And we removed 15 centimeter fibroid from liver, 13 centimeter from close to spleen, and 9 fibroids. And all those things done laparoscopically. So we removed 6, 7 fibroids and we sutured. If you can see, the gentleness seen over here is that we are not disturbing the uterus. We removed almost 8 fibroid, including the bigger one. And more than that, because we are not only popular, this is the tissue edema. So we are gently separating. 10th, 14th of July 2015, we started in-back morcellation. And we have finished now more than 10 years of content back morcellation with the highest in the world. So here also we removed in the bag morcellators. Fortunately, before they closed production of morcellator, I have only 6 morcellators with me. So nobody can stop our morcellation technique. Moving further, this was a rare case, which was renal cell carcinoma. At 30 weeks, retroperitoneally partial nephrectomy done, not by us, obviously by laparoscopic uro general surgeon. And she had this carcinoma removed at 30 weeks. And after that, apart from partial nephrectomy, she still continued pregnancy. And also there was a cyst of 6 by 4 centimeter, which also was removed. So we have to remember, this heterotropic pregnancy, we have plenty. Plenty means countless number of pregnancy. This was a review of heterotropic pregnancy by various people in 1995. We are sitting now in 2026. Heterotropic pregnancy, there's nothing to be worried. You can do salpingectomy, you can do salpingostomy, and you will in plenty of cases. Molar pregnancy, the first case reported was by Alka Kriplani, the same case which I showed you. So that is 1 in 18,000 of cesarean scar ectopic, which can never go ahead. Then this is a study of 5 years cesarean section ectopic pregnancy. Now, I and my friend late Dr. Rakesh Sinha, we saw this niche 1,000 times, more than 1,000 times. We never bothered about it. And nothing happened at that time. We never corrected the niche. We never got an ectopic pregnancy from 1992 till 2007. till people started becoming more and more conscious. Now, one thing I would like to give credit to Alka Kriplani is she has the largest series in aims of giving methotrexate, is irrespective of the pregnancy size and keeping the patient in the ward. All were treated. So cesarean-car laparoscopic pregnancy and decisions. So these are articles which are reported, 126 cases. So that one case required 2 methotrexate injection. But the point of the matter is she had the courage to keep giving methotrexate even at 82,000 HCG level. So the important point is you have to remember that if you believe in your science, you don't have to worry. Appendicectomy was started by my teacher, Professor Kutsem, for the world. So along with pregnancy, plenty of appendicectomies have been done, and it's a simple surgery, and it doesn't cause any problem to the pregnancy. Cholecystitis. Now I have unique fortune of doing cholecystectomy with pregnancy, even as late as third trimester. Obviously, the cholecystectomy was done by general surgeon because I don't cross my field. And successful cholecystectomy, as we told, 59% were laparoscopic, 4% were open. But laparoscopy was always superior. Then we have robotic. Robotic is the name of the game. Why I'm telling you the name of the game? Advantages or not, but patient want robotic surgery. And robotic surgery, now we have 7, 8 different laparoscope, the robotic surgery. So again, 38 pregnancy robotically were removed pregnancy out of the uterus, and there was no problem. I don't know why this slide comes. This slide only comes because if my previous text has not explained you, then your CV comes. Otherwise, I always tell. And there are too many things, and Billard has seen my presentation on parasitic fibroid, which is the largest in the world. Parasitic fibroid, largest in the world. And that will be published. And more important news for all of you is, in this year, we'll have somebody who did 32,000 laparoscopic myomectomy will introduce a system wherein 60% of fibroid surgery will get stopped. That is what happens only in India. Because if you're a good laparoscopic surgeon, everybody will tell why are you ruining our practice. But my point is, a good laparoscopic surgeon, I have identified 4 points. Genetically, single fibroid is HMGA overexpression. Multiple fibroid is epigenetic. But more important, I have identified prolactin, aromatase inhibitor, and progesterone receptor suppressant. We use it collectively. I have signed an MOU on 14 January only, after 6 years of waiting. And that product will come within 6 months, and that product will prevent 60% of surgeries for fibroid. Beauty about this product is that if you want pregnancy, you can remove after 9 months and can go ahead with pregnancy. So fibroids and pregnancy, fibroids and pregnancy and laparoscopic surgery is very unique. I do get distracted because we got at least one more wicket. I'm sorry to be obsessed with cricket. But it's like laparoscopic surgery, If the thing starts, you get. I mastered PhD in numerology, PhD in Vastu, and shortly it will be coming on. So it was a great honor and privilege to talk in front of a very enthusiastic Kasoga crowd and more intelligent people than me. So pleasure and thank you very much.
Thank you, Dr. Trivedi. I just wanted to see your that answer class video of the bulging membrane. If you can show that
Which one?
the bulging membrane video of
I
that.
saw this.
No, the
You want to
bulge.
see again?
Now that we wanted to see that how it disappears inside the vagina, how that part.
I will show you. I will show you. It's not a problem.
Because that others I have
Uh,
seen that in your Pune presentation, but I wanted to see that again.
yeah, I will try and open it. Laparoscopic surgery. My laptop is too hungry and so busy.
Your son Saumil's presentation on ICG in laparoscopy was fantastic in AICOG.
See, Somil is 100 times ahead of me. And the beauty about these people is that what we learned in 30 years, they learned in 2, 3 years. Additionally, they have the advantage of skill, good hands, and they have the advantage of most important advantages of technology.
Yeah,
I'll open my presentation because this presentation I had in Figo.
yeah.
Uh, 50 minutes presentation of laparoscopic surgery in pregnancy, followed by 30 minutes of question answer session.
It's
So
amazing.
I will just take it out. Uh, this is numerology. I did PhD, that is my passion, and it is going to be in a big way. Now let me, these were the unusual cases. This is a different presentation, but I'll show you in 2 minutes. Uh,
You had shown in Pune,
yeah.
Doctor.
So, um,
Yes,
taking
for the
advantage, what I showed in Pune was this also. Uh,
yeah,
so, this was a case wherein we were doing surgery for prolapse. And as I was talking to my son, I told you have to be very careful of left common iliac vein. And as I'm taking suture, this we started from 1992. But you will see heartbreaking changes. But the point about heartbreaking changes is very simple. Don't bother. Now I'm taking a deeper bite, always telling, be careful of the left common iliac vein, and this is what I've injured. Now, if you remember, I only punctured it. So my son is too cautious than me. He told we'll call XYZ, we called to cancer surgeon. Somebody told, no, you have to do with vascular camp, suturing and all. I was watching at the pulse and BP. BP was 130 by 80 and pulse rate was 86. So I told my anesthetist, my heart rate is not increased at all. So I called a surgeon friend of mine who normally takes 15, 20 minutes to come. So after he came, I still kept pressure because it's a venous bleeding. Still kept pressure. And retroperitoneal hematoma may increase in size. The worst thing for us to do is you open up. You open up and you got problem. The two famous cancer surgeons I contacted, they suggested me X and Y. I trusted my gut feeling. After 20 minutes, you see there's no bleeding at all. Nothing happened. Patient was from Delhi, had cardiac problems, had come for prolapse surgery to me. So important point is in complications, don't panic. Now this I will run through, but this is historically the greatest case ever happened in the history. First surgery done by Prashant Mangeshkar, laparoscopic myomectomy without bag. Second surgery done by Rakesh Sinha, open surgery shifted to Hinduja without bag. And she came to me with a 15 centimeter fibroid at the liver, 13 centimeter fibroid at the spleen, and 9 fibroids. So as usual, I told my friend Shailesh to be around. At 9:30 I'm starting. You can come around 11:30. By 10:30, I had finished the because see the parasitic fibroid. That's the reason why we do contained bag morcellation. So parasitic fibroid is always from the wall, is not from the bowel. So we separated the hepatic fibroid very easily. The other fibroid, my son was very particular because the so-called fibroid around the spleen were actually arising from inferior vena cava anterior branch. So this is the liver fibroid which we separated. The other fibroid which we separated because of his suggestion, and also the pedicle was so big. So we took 3 sutures. See the pedicle, how big it is. So I'm the only father who follows son's advice. And it's very good because you have to remember the younger brain are smarter and more particular. So we took 3 sutures here, and that was small pedicle that was removed. This is historically the biggest case in the world, wherein 15, 13 centimeters parasitic fibroid are removed after being done by 2 expert surgeons who don't use bag. And we removed this fibroid in 2 bags because I realized that you can only do removal of fibroid in bag and contain bag. Otherwise, this case would not have arisen. So we removed this. Then we removed in 2 bags. So except the bigger fibroid of the liver, we removed 9 fibroid from the pelvis and the splitting fibroid in 1 bag. Then we introduced another bag and removed. And bag, I think so everybody knows, we have been practicing for more than 10 years, the largest series in the world. This was the uterus. She wanted to keep the uterus, and this is the second bag which we are introducing for removing the large fibroid. So moving further, this was the weight of the fibroid. This was the scars. And patient was so obliged because now lots of time if we need, we can remove elephant from the vagina. This is our own case wherein a gynec, and I do remember because it was prior to Bangalore conference. We had done a hysterectomy with appendicectomy, and my anesthetist told nobody can do better than you. She reported back because we had removed the specimen vaginally. She reported, sir, there are some tumors down. And we realized that they were fibroids on the vault. Like normal laparoscopic surgeon, they always tell, my assistant did this, my assistant did this. My assistant didn't do it. I did it. We removed. She has a huge story between me and Alka Kriplani. She had bowel obstruction, etc. But you can understand that after a clean removal of uterus with fibroid vaginally, we had 6 fibroids on the vaginal vault. So we removed all of them. I will not block your time. So that was vaginal vault. This is the data of vaginal vault. This is the data of vaginal vault fibroid. This is a South Indian teacher, historic. She had 100 fibroids. She was kept for a surgery from xiphisternum to symphysis pubis. And when I and my son went in 1 second we realized it was leiomyomatosis peritonei. So we removed almost 50 fibroids. And we told her there's nothing to worry because number one, they're non-cancerous. And as I told you, in this year, you will get our solution for fibroids, which is non-surgical. So we removed 50 fibroids and told her, you don't worry, nothing will happen. These are details about the. This was another rare case which Krishna Kumar keeps giving me bad cases. He told that a variegated appearance in one of the IIG workshop. And then I started dissecting. And on the same day in the morning, they had done one surgery wherein they opened the patient for fibroid. And when I started operating, the audience was in pin drop silence because they were thinking, why is not using myoma screw? Because I realized that this was only a vascular structure. So this was a posterior wall. We thought that anteriorly we may be fortunate. Nothing happened. We removed both, sutured, and when we put it into the bag, you will realize nobody on the earth can tell that what is this pathology. Out of 41 cases of angiolipoma, this was the 29th case. So basically, you have to understand that in laparoscopic surgery, this is the data about the angiolipoma. I may show you this as the last presentation. One of my IVF friend's son was my assistant. And on the right port, he used to be very aggressive. So one of the right port, he had made from 5 to 1.5 centimeter. And we realized on day 2, day 3, patient didn't have peristalsis. We did MRI and we realized that there was bowel herniation. So we laparoscopically, we reduced the bowel herniation from a 5 millimeter port, which is extremely rare. And peritoneal settling, this fibroid, that fibroid. I think so. You shot too many things. So in conclusion, I'm missing the film which you wanted. But in conclusion, what I'm trying to give you an idea is that you can have all the problems in the world. But what has India given us? India has not given us Trump. India has given brains. India has given hands. India has given skill. India has given surety. India has given us God and believe in God. So my fundamental point is never doubt your own skills and never be worried about any problems and complications. So I will take your liberty, and I think so 64 over 1 it is going on. I'm not bothered. We'll still win. We'll still win. But talking for Katsoga is like my homecoming because I became president of IIG. I became president of IIG in Bangalore. And the best part about Ramesh was minimally invasive surgery. he forgot the president's talk. So Kamini Rao was there, Hema was there, and he's such a nice endoscopic surgeon that he has forgotten the presidential talk. So told that I will make it minimally invasive. In 2 minutes, I'll give you the presidential talk. But I have great memories of Bangalore and Karnataka, and pleasure to talk to all of you. Thank you.
Yeah.
Thank you, sir.
Yeah. Prakash, it was a wonderful presentation. I really appreciate and give it's a big hand to your presentation. I think you are the only person I feel that both the IAG, ISAR, and the Foxy president, and maybe Sunita may be joining with you. So thank you so much for that, and thank you for obliging to our request. It was an amazing presentation.
My pleasure to Dr. Billard, Durga Das, Jyotika, and 80% of Bangalore Gynaec are known to me. Durga Das, sir, you wanted to ask some question.
No, sir, no, sir. It was mesmerizing. It was really mesmerizing, sir. There's no word. I was just awe about the presentation.
God,
Whether,
God is kind. God is kind on us. That's what we can do.
there's a magic in your hand. The skill is a real magic what you have. That's what I was. Other day I was talking to Bhaskar Pal. The same thing. Everybody cannot do this. Well, those who are the magic hands, they only they can do that. Thank you, sir. Thanks for obliging for Kasoga. Thanks a lot.
Anybody can do if you believe in your skill, your brain, and God.
Anyhow, we are all obliged, very much honored that you have joined this evening. Thank you.
Thank you. Thank you.
Over to Sonia.
Thank you very much, sir. I think before we conclude and take the remarks, we have Dr. Shobha Gudi also here, Secretary of Kasoga. Ma'am, your comment?
Shubhagadi is a genius.
Yes. We see her on screen now. We can't
bowl,
conclude without her remarks, sir.
She will bowl me out as a spinner.
Oh my goodness.
Yes, Shubha.
Sir, what an honor today, and what a feast we had of laparoscopic surgeries. Actually, sir, there is a fan club for Prakash Trivedi, and we are all kind of ardent members of this fan club.
Shubha, I'll tell you a very important statement. My UK fans, they have a UK fan club for Dr. Prakash Trivedi. And they only tell, you come and only show your videos in UK, half of the UK will go paralyzed. But it is because of God's kindness. Thank you, Shobha Madam, for your kindness.
Very nice. Sir,
Vidya to be-
very, very wonderful surgeries you showed. But thank you so much. Thank you. Yeah, Vidya. Yeah.
Yes, I just want to compliment and endorse what Shobha says. And also, I want to add, we are also fan of Dr. Saumil's videos and his talks also. So we enjoyed thoroughly today's evening, and I must thank Dr. Bella, Dr. Sonia, and all my Kasoga friends for giving us opportunity to listen to you. And we don't want to come in between your cricket and us, but you have taken all the wickets of
Cricket is going on the side. But I'm very happy. I am happy.
Vidya, it all started with Pune's.
Yes. So I know Dr. Prakash very well from the beginning. I meet him often, but definitely we don't want to come in between the cricket and yourself, but you have taken most of the Kasoga's wickets.
Cricket goes on, we'll win. But what I want to tell is my son is phenomenal.
He is phenomenal. I have been observing him. I'm following him.
More important is my daughter-in-law in IVF.
Yes, daughter-in-law as well. Yes.
Sir, एक बात मैं कहना चाहती हूँ. It is actually, you're a very proud father, and it is very understandable. And of course, Saumil is such a promising one, and we look forward to his growth in every way. But sir, when you started as a laparoscopic surgeon, the equipment was not this developed, and neither was patient's acceptance. So you have made a mark which is indelible. And I feel that those who started laparoscopy early and made this kind of place for endoscopy in gynae practice, the
You know,
credit is very, very high, sir. Very
you know,
high. Today, it is easier for youngsters to take it up, and the
see,
equipment and all is so good today. Yeah,
Shubhagudi madam, 1983, I got my gold medal
Goito.
along with
Yeah.
me and Rakesh Sinha. And my
Correct.
role model was Kapil Dev,
Okay.
who brought the World Cup in the same year.
Same here. Yes. Yes.
All Indians should be very happy and proud of
Yes.
our own skill.
Yes.
Never doubt our own skill, whether you're obstetrician, whether you're
True. Very true.
vaginal
Very
What a
true.
surgeon,
message to
whether
give.
you are whatever it is.
What a message to give. Hats off to you,
And
sir.
the biggest message to give is, apart from my son, my daughter-in-law is the greatest. And
Yeah.
this is what we have to cultivate. This is
So
what we have to
nice, so
cultivate.
nice,
Okay,
sir.
my wife is a
So
big
nice.
embryologist.
Thank you.
Sir,
Thank you.
in continuing with the wishes, sir, before Treasurer Madam Dr. Suman Gedi takes over, I would actually, on behalf of the entire Kasoga and KCOG family, extend warm anniversary wishes to you, sir.
Thank you, Sonia. Thank
Yeah.
you.
We have already
Please
used
convey
this.
our
We
wishes to
only,
Madam also,
yeah,
and
we only
wishing many
finished.
more years together, sir.
We finished only 44 years, but when we see
Wow.
the photograph, we feel we are still too young.
Mm.
A
Thank
very
you
happy
very much, sir.
anniversary,
Very
Dr.
beautiful.
Prakash and Madam.
Yes, sir. Thank you, Arun, sir, for
Thank you.
displaying this also. And
Correct.
over to you, Madam Dr.
And
Suman.
thank you, Bellad and Sonia. This was a lovely evening we had. Thank
Very
you.
nice. Very. Thank you.
Thank you.
It
Suman ma'am,
started
over
with
to you.
myself and Bellad in Pune.
Yes, yes.
Okay. Okay, Dr. Durgadas. That was wonderful that you thought of bringing them here. Thank you.
Pleasure.
Madam Dr. Suman Gedi, please.
It was a wonderful presentation, sir, Dr. Prakash Trivedi, sir. And of course, there are only two questions. Most of them were, only appreciations of what we have received in the chat box. Only two questions. One is from Dr. Sonia, that is the role of prophylactic tocolysis.
Not needed.
Not needed, sir.
Though we give it, see, uterus gets stimulated by prostaglandin. So if you are in the periphery of the uterus, but to be very honest, we give progesterone, we give duodelan, everything we give. You can't take any chance.
Okay.
So that is practical aspect that you gave it.
Yeah.
And second question is, where to learn all these techniques in laparoscopic surgery, sir? And if any government center is there where training is given, somebody asked this question, sir.
Anything is possible in India. No, I will tell you. I have trained 2,000 consultant in IVF, urogynec, laparoscopic surgery, and they all are bigger billionaire than me. And they are even bigger in some branch. Somebody may be big in endometriosis, somebody may be big. If you want to learn, nobody can stop. See, when Prashant and Rakesh, we came back from abroad, we had no thought block. We only thought that this has to percolate in India. And both Kutsam and Inclamafuran, we told them that whatever you tell, without this you cannot do. I will bring you without endomat hysteroscopic TCRE. We were fortunate to have the T-suit tape. We are fortunate to have contained back morcellation. And this product, when this comes out of a fibroid, 60% of the fibroid surgery will not be needed. In fact, today only from my place, one doctor from Durgapur and her daughter from Delhi came to my place, and I had done a surgery. Now, apart from surgery and telling she doesn't need anything more, medicine and all, I gave them a package of my numerology. I'm rank 4 in numerology in India. And I take this as a complimentary gift. And all branches are exciting.
So one can learn anywhere.
Yeah.
Self-learning. More
You have to
important,
find out. I
you have to
have
find out.
I have gone to 25 conference. 25 conference. After conference, 2 weeks I spent time with Charles Coe, C.Y. Lu, opposite people. Sem and somebody else. So see, you have to learn from arch rivals without informing them where you have gone earlier. And you can get the best of it. And India is flooded. India is flooded with skill. You should only have the brain to follow it up.
Okay.
Okay, sir.
Thank you very much, sir. And
much, sir.
before we move on to the official delivering of vote of thanks by Secretary of Belgaum OBG Society, Dr. Rajeshwari Patil, and this August gathering in the presence of our speaker of the day today, past president of Foxy, Professor Dr. Prakash Trivedi, and in presence of our president of KCOG, Dr. Durgadas, and Secretary Madam Dr. Shobha Gudi, and our Dean, Dr. Bellar, I would like to congratulate Madam Dr. Vidya Thobi. Madam, for her post, Vice President post of Foxy, and congratulations to you, Madam.
Thank you very much. Thank you.
On
Thank you,
behalf
my
of all of
Kasoga.
us, we are
Thank you. Thank you.
congratulating you.
Thank you very much. Thank you.
Thank you, Arun sir.
What is obesity? Obesity is a chronic relapsing
Over to you,
condition.
Doc.
Most of the
Thank you very
explanation
much.
system,
Thank you.
they
Thank
are
you.
trying to.
Over to you, Dr. Rajeshwari Patil.
Yeah. Thank you. Good evening, all. Today is last session. It's my honor to deliver the vote of thanks on behalf of KCOG in association with Kasuga, Blocks, Kahir, JNMC, Belgaum. I express my gratitude to Dr. Prakash Trivedi, sir, for his excellent presentation and broadening our knowledge on laparoscopic surgery in pregnancy. My sincere thanks to the organizing team, KCOG, Dr. Hiremat sir, Dr. M.B. Bellat sir, Dr. Vidya Bhatt madam, Dr. Sonia and Dr. Suman. And our associations, Kasoga office bearers, Dr. Durgadas sir, Dr. Bharti, Dr. Rajeshri Palladi, Dr. Shobha Gudi madam, and Dr. Shobha Bembalgi madam for their support in organizing the webinar. And my sincere thanks to all the delegates and participants who have joined in large numbers today and made the webinar interactive. I thank Mr. Arun for his audiovisual support. I thank one and all.
Thanks. With your permission, I will leave the event.
Wonderful, Prakash. Thank you so much.
Thank you.